Hello.
Alaikum.
Walaikum salam. We meet again.
Yes, right. Thank you for the opportunity.
Uh,
Uh,
yes, we can get started. Let me just do a quick introduction and then I think we can utilize this time. And as you are on call, I'm actually post call from night shift and I had a very busy night, one of the worst ones I can name. Okay, so we welcome you all for our monthly activity. And this is getting more exciting with time, I feel. And I'm very excited for the talk today. And it is my honor to introduce you, Dr. Aamer Imdad. He is a good friend. He's a pediatric gastroenterologist. He's an assistant professor at University of Iowa. He is one of the rare thing. He's a tenured track faculty, which you hardly find nowadays because it's very competitive. And as he mentioned to me, please keep my introduction short. So I'm gonna keep that short. He is well known for his academic work. He has near 100, articles authored, mainly on nutrition and feeding. And I was going through some of his work. It is so impressive. So before taking more of your time, I'm going to move this podium to Dr. Aamer Imdad. And Aamer, thank you so much for doing this for us.
Absolutely, my pleasure. Um, so I'm going to share my screen and also that you tell me you can see okay, right? It's the main slide, correct?
I can see it perfectly fine. Yeah.
Perfect. All right, so thank you so much. So we are gonna look at approach to conducting systematic reviews and meta-analyses. And my hope is that I give you an example and then kind of and go through the process and share some sort of practical tips on how to go about conducting a systematic review with meta-analysis. So I don't have any conflict of interest, but the opinions shared in this lecture are of mine. I'm not representing University of Iowa here, and I just wanted to make that very clear. So what we're going to start with is really in order to do a good systematic review, we need to ask the right question to start with. And so kind of go over how do we come up with the right clinical questions. And then we'll understand what is the purpose of a systematic review, and then what is the advantage of adding a meta-analysis to a systematic review and how they are similar or different when they are done together. And then once we have a good question for the systematic review, how you approach to do the literature search, and then screening of title and abstract, which is the next step to it, data extraction, meta-analysis, and interpretation of results. So at the end of this, we will hopefully be able to understand these approaches to conducting a systematic review. So in the case and the work that I'm going to share with you guys is something that is being actively done. This is work that I've been doing with Dr. Butta for a while, and is focused on a neonatal case that I will start sharing here. So case is a 3-day-old term baby who was born via spontaneous vaginal delivery at home, but in a rural setting in Pakistan. So the baby initially presented with a picture on the left in a rural clinic. The baby had lethargy, poor feeding, and mild periumbilical erythema. So yeah, the baby could potentially had sepsis, but that was missed, and baby was discharged home without any major interventions at that time. Then baby returned 2 days later with now fever of 39, significant abdominal distension, tachycardia, and respiratory distress, showing multi organ failure related to septic shock. And the baby ultimately did not survive. This is a sort of a hypothetical case, but very much real in terms of how the neonatal sepsis could present very subtle initially and can get complicated very quickly and can lead to mortality. So just shining more light on this particular aspect, the questions that could be asked, could this have been prevented? So are there any preventive measures, especially for births that happen at home in the rural settings? And could we consider a use of prophylactic topical application of an antiseptic for the routine cord care, because the cord stump itself can act as an entry for infection. And there has been data to show that um, the omphallitis can lead to sepsis. It and does increase the risk of neonatal mortality associated with sepsis. And then if there is an antiseptic, which one is the best one to use, and what is the evidence behind that? So, in order to kind of investigate this further, we're going to do almost like a very academic textbook, like picture on finding an evidence-based solution for that. So, when we talk about, okay, what are the, say, evidence-based approaches for an intervention in this particular scenario that could have prevented the omphallitis and related neonatal mortality? So the very first thing would be to define what exactly is evidence-based medicine. So when you define evidence-based medicine, it's the integration of the best research evidence that is used in the right clinical setting and expertise that involves and takes care of patient unique values and circumstances. So evidence-based medicine is not only research, it also includes what circumstances are we working, what resources are available, what patients really want in terms of their care. And we will kind of loop back to this towards the end of the talk on how the interventions that we have going to look at would kind of fit into the scenario of umbilical cord care in community setting in low and middle income countries. So, so when we're looking at the evidence-based medicine, there are kind of 5 steps to it. So the very first step is to ask the right clinical question. And we'll go through some details on how to approach that. Then once we have the right clinical question, the next step is to acquire the best evidence. And then once you have the evidence, then the next question is how good or limited that evidence is. And then once we kind of determine sort of the appropriateness of the evidence, then the next step is how to apply that. And once you apply it, then you got to assess how you're doing and if the patient outcomes are improving with application of the interventions based on that evidence. So we'll cover most of these steps. So the very first thing is to ask how to ask a clinical question. So when you think about clinical questions, so there are 2 types of questions. One is the background questions and then the foreground questions. The background questions are the ones that talk about very basic general knowledge about an illness, disease, condition, process sort of thing. So usually these are what, where, how, when, about things, about a disorder, about a test or a treatment. So for example, in this case, a first-year medical student may say, oh, what is an umbilical cord, or what is the definition of omphallitis, and what is the definition of sepsis, for example. So that's sort of very basic sort of information or knowledge that you get about a particular condition. The foreground questions are more focused on specific knowledge to answer clinical decisions. So these typically includes a scenario or a patient population, and they could address unique circumstances. They may compare, for example, different interventions, and new intervention with a placebo or no interventions, or 2 interventions together, 2 medications together. It can also assess the diagnostic test. It can also assess the prognosis as well. And then if you're going to look into foreground questions, they could be further broadly categorized, even though there are more nuances to it. But broadly, they could be further categorized into treatment or therapy-based foreground questions, or diagnosis, prognosis, or etiology. So the best way to go about a foreground question is like a PICO format. So PICO stands for P is for population, I is for intervention, C is for comparison, and always for outcome. And there's more nuances to it as well. There are some people consider taking time into this consideration as well, and the settings as well. But in a typical scenario, you would say that, for example, for an intervention or a treatment, you want to assess the effect of an intervention compared to another intervention or placebo for a particular condition in a particular population in a certain context to reduce certain outcomes. So for our case, uh, a PICO question might be, okay, to assess the effect of umbilical cord antiseptics compared to dry cord care for preventing omphulitis, and that's in units in community settings. So that would be one example of a PICO-based foreground question that could be answered with a with a study design. So once we have an appropriate question, then the next step is, okay, how we're going to answer that question. What is sort of the best evidence to address that question? So, so this particular pyramid is more sort of focused on therapeutic interventions or even diagnostics studies, and there are sort of nuances in terms of if this pyramid could be applied to all type of questions, but this particular scenario that we're working on, the least sort of evidence would be an expert opinion or editorial, and then the case series and case reports, followed by case control studies, cohort studies, especially the ones that are prospective in nature. And then the randomized controlled trials are the highest level of evidence in terms of the investigational studies, and the systematic reviews typically synthesize the evidence from randomized controlled trial, and it's considered the highest level of evidence. There is even more on top of systematic reviews, which are guidelines that consider more aspects of decision making, and we'll touch upon that towards the end of this presentation as well. But for a typical intervention in a scenario where we're looking at an intervention, this is how you would kind of look at the evidence that what is available, and then depending on the study design, you can define your level of comfort on how strong is the evidence to answer that question. Now, because the talk today is more focused on systematic reviews, so we're going to define systematic reviews. So systematic reviews are it's a systematic investigation that attempts to identify the literature, then appraise that literature, and then synthesize all the evidence together, looking at the strengths and limitation of that evidence, and all what we're looking in the systematic review should be defined in a pre-specific or pre-specified eligibility criteria, exclusion criteria to answer a specific research question. A meta-analysis is the statistical combination of the results of two or more separate studies. So systematic reviews can have meta-analysis or they may not, but most of the meta-analysis typically are part of the systematic reviews. So there are very few scenarios where a meta-analysis could be considered without doing quote-unquote systematic review. For example, a pharmaceutical company or a group of investigators do multiple studies in different locations and they want to pool their data, they can do that without doing a more generalized systematic review. But as a rule of thumb, all the meta-analysis are systematic reviews, but all the systematic reviews may not have meta-analysis. All right. Now, talking more, what type of questions can be answered with the systematic review? So we're talking about like an intervention or treatment, efficacy. The systematic reviews can also address questions related to etiology, where most of the study will be observational in nature. You can also do a systematic reviews and meta-analysis for a diagnostic test. It can also be used to study economic evaluation, including the cost-effective analysis. It can also do the group differences, and if we have time, I'll show you guys an example where something called network meta-analysis can compare different or multiple interventions for the same condition and say which intervention is the best intervention. And then the systematic reviews can also look at interventions or natural history of a condition, including things like prevalence and incidence as well. You can pool the prevalence or incidence of a given condition and define the epidemiology. of a particular condition. All right, so when somebody is thinking of doing a systematic review, the first step is to define the problem, and we talked some about it. And the best way is to define a PICO question for it. Then once your PICO question is very well defined, then you search the literature, and once the literature is done in a comprehensive way, then we screen the search studies with their first starting with the title and abstracts, and then define which studies should be included. Once we have a final list of included studies, then we do the data extraction, code that data, and do a critical appraisal with the risk of bias assessment, and then attempt a meta-analysis if there are similar and enough studies that were included for that systematic review to pull into a meta-analysis. And then there are methods to report your results and disseminate it. And then the final step is to update your meta-analysis once the studies and the data has kind of is being updated. So I'm going to show you guys an example. This is something that we published back in 2013 with Dr. Butta. There's an update of the work that we submitted, which is under editorial review. So you guys have this unique access to this data in terms of what is being updated. We looked at, this is a part of a Cochrane review, where we looked at the different antiseptics for preventing sepsis and death among newborns. So in this particular Cochrane review, we had looked at multiple antiseptics. We actually had looked at antibiotics as well. Of all the interventions that we studied, the most literature was related to topical application of chlorhexidine, and 70% topical alcohol application. Even in these two, the evidence is kind of the most for topical chlorhexidine. And there's data from community trials from low and middle income countries, both from South Asia and Africa. There is some data from higher income countries as well. The data for topical application of alcohol is available from both as well, but it's limited, and there are not that many trials for topical alcohol application. So for the purpose of this particular talk, we're going to just focus on the chlorhexidine, which has the most evidence. So in this particular, say, for example, we are looking at all the evidence related to topical application of different antiseptics. And now the next step is to find the literature. So the best practices around defining a search strategy is if you have access to a librarian, that's the best case scenario, and you share your PICO question with the librarian and kind of involve them right from the beginning so that they kind of know what your population is, what your intervention and comparison is that can help you define a very comprehensive search strategy. Typically, when the literature search is complete, then you download the results to a software like EndNote, and it can help deduplicate because you may find studies in different databases which are the same studies. Now, of the databases that should be searched, PubMed or Medline is sort of the most common. It's freely available. Medline mostly includes the research studies, but the PubMed also includes additional things as well, including book chapters. Lilacs is another database that includes studies from Latin America. Scope is PsycInfo. Cochrane Library maintains a database of randomized trials called Central. And if you're doing a Cochrane review, they will help you search the Central Library as well as the other databases that are mentioned here. It's very important to also look at the gray literature as well. So the gray literature is the one that is typically not, say, available on the databases that are mentioned, or is more in the form of, say, dissertations, for example, or the material on the softwares like, on the websites like WHO website or USAID website or FDA website. Even the clinicaltrial.gov, where the the trials are registered. Sometimes they're not published, but they put their data there. So it's very important to look at all the places where the data could be available. And for a given intervention, all the data may not be available in a peer-reviewed literature. So it's very important to make a strategy around looking at the gray literature, looking at the abstracts of the large conference like Pediatric Academic Society meeting, and then the, conferences that are relevant to your field. For example, in our case, NASPGHAN, or DDW, which is a large conference that happened for, say, gastroenterology. Now, talking a little bit more specifically for this particular example, for example, is the search strategy here for PubMed. And as you could see, there are different terms that are listed here. And here, for example, is antiseptic. And this star, which is done at the end of it, what it means is that we are exploring this particular term. So what that means is that anywhere where this is mentioned, and there is an antiseptic or antiseptics, or any variation of the spellings around this word capture that. And same as goes for antibiotic. And then these or and are would help kind of define on how inclusive or how limited your literature search would be. And it's typically done in different phases. Like you would define your, say, intervention here. So you would consider anything that is antiseptic or antibiotic or chlorhexidine or sulfadiazine or neomycin. And then you will compare that for umbilical cord, because these interventions could be used for other indications as well. And then you would compare that, include that with infants or newborns. And you would see here on the slide that there are some open terms, which I mentioned here, and then there are some mesh terms here. So the mesh terms are these terms where the PubMed or Medline store certain studies. So they will code the studies and will connect that with the mesh term. So any, say, for example, a mesh term that includes newborn will include all the studies that where the newborns were included. And then in addition to your, say, intervention in the population, you can also include your study design as well. You can limit your searches to, say, randomized controlled trials. And there are certain terms that could be added to the search strategy. The search strategy approach is different for each database. So the librarians have really good grip of these things. So, if there is a scenario and access to a librarian is highly recommended and desirable to include them. So Embase, for example, has a different approach, and they may not have mesh terms as those are available in the PubMed search. All right. So once the literature search is done and is available and downloaded into a software, the next step is to do a title and abstract screening. So typically the recommendation is to do 2 reviewers as part of the screening. So they should look at the title and abstracts independently. And then once they decide, okay, this study should come in for a full text review, if there is a consensus, then that full text would be reviewed. And if there's a conflict, then they need to talk about why there is a conflict and resolve that. Once you have a list of full text screening studies, then 2 people also look at the full text and vote on that. And then again have a consensus on what should be the final list of studies. Some of the softwares that could be used for it is so Covidence and EndNote could be used for it as well. Covidence is a software, and I'll show you guys a glimpse of the Covidence. It's free if you're doing a Cochrane review, and for non-Cochrane reviews, you can buy a subscription for it. Abstractor is a software out of Brown University. It does a very similar job of Covidence, even though it would only help you do the title and abstract screening. Covidence could also help with data extraction. And Distiller is another software. And then Ryan, I have never used it, but I heard this is a free software. So I'm going to show you guys the data extraction part of it, and then I'll show you guys very briefly how the covenants is laid out and how it works and how it can be used. So say, for example, after the title and abstract screening, the next step is to design a data extraction sheet and code your data. And there is a range of things that are required, including the study characteristics, what the inclusion exclusion criteria in each individual study is in terms of the population, intervention, comparison outcomes. And another very important aspect is to do the risk of bias assessment, and the Cochrane has the different risk of bias tools, including those for randomized controlled trials and observational studies. So Cochrane Risk of Bias Tool 2 is a newer tool to assess the risk of bias in randomized controlled trial. There are other tools by AHRQ, which is the Agency of Healthcare Related Quality of Research, and then NIH and Ottawa Scale. Cochrane also have additional risk of bias assessment tools for observational studies that are focused on an intervention or exposure. So those are called Robin's I, Robin E, as part of the risk of bias assessment. So I'm going to show you guys, if I can, hold on, the COVID so that if any of you guys are gonna have to use it here. So I'm gonna bring this here. So this is how, say, covenants look like, and we're working on a number of things here at the moment. So one of the things that we are focusing more recently is vitamin A supplementation for children 6 months to 5 years of age. So for example, we have done these searches and we brought the searches here into the software. So there are, for example, 3,140 title and abstracts to be screened. So I have my team who's helping us. So what it will show is it will show you the title, and then it will show you the abstract. So based on your inclusion exclusion criteria, you will review the title and abstract. The idea is to kind of briefly review this, not go into a lot of detail, but then decide if this is totally out of the scope of what we are doing, or is this something that could be considered for inclusion. So for example, we are looking at randomized controlled trials that are focused on vitamin A supplementation in children 6 to say 59 months. But this is a proceeding from a conference, which is not an inclusion criteria for us. So I can just say no here. Similarly, these are the proceedings of an international conference, which we are not interested as part of a study design. So I can say no here. So similar case up here too. So you can look at the title and look at the abstract and decide which study should be included or included for full text review or should be excluded. And then a similar exercise will be done by another team member and the two boards. Then the software will show you the consensus on where did you guys agree, both for the inclusion and exclusion, and where there was a conflict. And then it will give you a list of conflicts. Then both the reviewers can go and resolve their conflicts. Most of the time, the things are very straightforward, but say if there is an ongoing conflict and the two individuals cannot resolve that, then typically a senior investigator on the team would help resolve that conflict. All right. Now, and then the software also have a data collection sheet. You can actually design a data extraction sheet on the software, including those for risk of bias assessment. Once the data is there as part of in terms of getting ready for meta-analysis, you really need to decide what outcomes are you interested to perform a meta-analysis and how you're gonna decide which summary estimate you're gonna use. So for example, if it's a continuous outcome, like for example, if we're looking at z-scores for weight for age, for example, or height for age, or say blood pressure, for example, then for those sort of outcomes, you can calculate a pooled mean difference or a standardized mean difference. Mean difference is used when all the units of an outcome for a continuous variable is given in the same units, or you can use a standardized mean difference. For example, if the weight is given, say in some studies given in kilograms and in some studies given as z-scores, you can still pool that data and get a standardized mean difference compared to a mean difference where the data has to be in the same units. Similarly, if you have a dichotomous outcome, for example, mortality, yes or no, onpholitis, yes or no, in those cases, you have to decide if you want to calculate the relative risk or odds ratio. You can also calculate a risk difference or a hazard ratio, and hazard ratio is an estimate where you consider time as part of the estimation of the pool estimate as well. And then once you have decided which outcomes you're going to measure in which way, then the next step would be to find a model that will help you pull the data. So random models or fixed effect models. The random models are the ones that assume that there is a heterogeneity in the studies. So there is some heterogeneity in the pool data that is expected from study to study. But in a random model, you say that there is additional heterogeneity from one study to the additional study. But in a fixed effect model, you assume that there is no further variation from one study to the next study. And the heterogeneity itself, it can be defined in multiple ways, but the statistical heterogeneity is typically measured with an I-squared, and I'll show you guys the forest plots to have more discussion about that. You also want to talk about your subgroup analysis and publication bias and how you're going to assess that. In terms of the logistics of how the meta-analysis could be done, actually meta-analysis could be done in Excel. I have done that in the past. So the Excel most of us have access to, and there's some really good videos on YouTube that you can see. So if you have very limited resources, it still can be done in a software like Excel, or if you have access and knowledge, it's freely available, and there are really good packages in R that can help conduct a meta-analysis. The Stata also have really good packages to conduct the meta-analysis, but it's not free. Stata, you need to pay for it, and SPSS also have packages that could be used for meta-analysis. RefMan or Review Manager, which I'll show you guys, is software by Cochrane. You have free access to it if you're doing a Cochrane review. You can also buy the subscription if it's a non-Cochrane review, and it's a very user-friendly, and we have done a lot of work, and most of the work that we have published in the past, we have used Review Manager to conduct our meta-analysis. Once the meta-analysis or evidence synthesis is done, then you want to rate the quality of evidence. How good is that evidence? And you rate the certainty of evidence for a given intervention, for a given outcome, and you define that as a high, moderate, low, or very low. And there are criteria that are based on that. So study design, your risk of bias assessment, imprecision, inconsistency, indirectness, and magnitude of effect. And we will kind of look through some of those with the example that I'm going to show you. Another aspect of it is that once you have the evidence, then you need to develop a recommendation out of it. And there are additional things that are looked at, including the balance between desired and undesirable consequences. So even the outcome might be very convincing, but if you don't have enough resources or you don't have access to the interventions, it still may not be very applicable in a certain setting. But reading the quality of evidence is sort of the final step in terms of completing your evidence synthesis to come up with summary statements for a given intervention, and something like, for this particular condition, this intervention has, say, a high certainty of evidence or moderate certainty of evidence for this outcome. All right. And there is a software that can help you do the analysis, and I'll show you guys just in a minute on how to use this. All right, so once you have completed your evidence synthesis, then the next step is to follow the guidelines for reporting. So there are PRISMA guidelines that are for reporting of the systematic reviews and meta-analysis that typically require inclusion of like a Prisma diagram, which I'll show you guys. There is a Prisma checklist as well that goes through each and everything that should be included. So if you have written a systematic review and meta-analysis, most of the journals would require submission of a checklist, a Prisma checklist for submission. The typical and core components of a manuscript for systematic review should include, the introduction and the methods and the results, and then the tables include the tables include the characteristics of included study table and excluded study table, forest plots, funnel plots, and summary of finding table, which is the product out of the grade analysis. All right. So let me just quickly show you guys Grade Pro, which is, let's look at the review manager first here. So this is a RevMan, and the software is very nicely laid out in terms of how it is. It helps with with writing the review. So it has different sections where you can see, it has different headings for, say, abstract. It has a plain language summary as well. And then it includes the summary of finding tables, and then it goes through the different section of the systematic review, and it will help you kind of follow those guidelines. So Cochrane has its own guidelines that are also mirror the Prisma guidelines for reporting as well. So if you kind of follow this layout and template, you will come up with a really high quality systematic review. And again, this could be done for Cochrane reviews, and the Cochrane now have given this access for non-Cochrane reviews as well. So you can use it for any of the systematic reviews. One thing that I wanted to show you guys was that, the analysis could be done here, and I'm going to show you some of the data here, but just for example, for all-cause mortality, you can enter the data here and it will generate the forest plot for you and the summary estimate, and you can also link your risk of bias associated with it. Now, in addition to that, I am going to show you the Grade Pro really quickly as well, and then we will just look at some of the data that we are talking about. So for the Grade Pro, here, I think the software is opening right now, right here. So Grade Pro, you can just sort of log in, and it will show you the different, for example, this is one of the study that we did. So it will give you these tables, and it will lay out these different criteria for it, and you can pick on how confident you are in terms of your study design, risk of bias. It will take the data from you and then come up with an absolute effect and do the rating, and then you can export that for your analysis and inclusion in the manuscript. All right, so let's look at the data related to the case that we are doing. So this is a Prisma diagram for the Cochrane review that I just mentioned to you guys. So we just submitted an update of that, and as part of the update, we had 9 studies that were included from the previous version, and then we looked at more than 1,500 titled and abstract, included 8 more additional studies. So we have a total of 17 studies on different aspects of umbilical cord care. So I'm going to show you guys the forest plot, which is the first one looking at all-cause neonatal mortality, chlorhexidine versus no chlorhexidine. Explaining the forest plot, which is the way to show your data for meta-analysis. The leftmost column has the name of the studies, and then you have this raw data, which could be part of the log of relative risk or a standard error. You can also include your number of events in both intervention and control group. And then as you kind of go towards the right, the software will show you how much is the contribution from each of the study to the overall meta-analysis, and it will show you the individual relative risk from each of the study. And it will show that in writing here and in the plot right here. So of the pooled studies from 5 different randomized controlled trials which were done in 5 different countries. APPNA was done in Bangladesh. It was a 3-arm trial with a single application of chlorhexidine, multiple application of chlorhexidine versus dry cord care. Molani, 2006, was a study from Nepal. It was also a 3-arm trial with chlorhexidine, multiple chlorhexidine application versus dry cart care and a soap and water treatment for the umbilical cord. Sazawal and Semru are studies from Africa. I think one was from Zambia, other was from Tanzania, and Dr. Sajid Sufi and Dr. Butta published a trial out of Pakistan, and I was a co-author in that as well. So this was a factorial design trial. So based on the data from these 5 trials in the community settings, overall, there is about 14% reduction in all-cause neonatal mortality if you apply chlorhexidine at the umbilical cord. And the relative risk around it includes 0.73 and 1.01, so it's not statistically significant, but then it just approaches 1.01. And there are more nuances to it, which I will talk just in a bit. When you look at the numbers that are reported as part of the forest plot, you see the Z effect, which kind of mimics the p-value of this summary estimate. You also get this heterogeneity, and we pulled this data by using a random effect model, which reports a tau square, which basically give you a numerical value of how much is the variability from study to study, which is 0.2 here. It will also tell you a p-value if the results are heterogeneous or not, and it gives you this I-square value, which tells you that from study to study, about 59% is what is not explained when what expected when you were pooling the studies in a given meta-analysis. So putting this together, this moderately heterogeneous estimate shows that there is a reduction in all-cause neonatal mortality, even though it's not statistically significant. You could also see the risk of bias in the included study on the right side. Now, the omphalitis data was more convincing. So this is any omphalitis. The way the omphalitis was defined in the included studies varied significantly. So we included the definitions that was the most inclusive out of these. So the reduction is somewhere about 29%, and these results are statistically significant from study to study. When you look at the severe omphalitis, the reduction is really high, so more than about 71% reduction, and it was very convincing that it does reduces the risk of severe omphalitis when applied topically. One thing that we were considering as part of sort of an adverse effect is the cord separation time. So among the studies that applied chlorhexidine, the cord separation time increased by about 1.85 days. And this was statistically significant. Here is important to note that this is a continuous outcome. So the way you define statistical significance in a continuous outcome is that the null value is 0. So anything above 0 or below 0, and if the confidence intervals do not include 0, then it will be statistically significant compared to, say, relative risk on odds ratio, where if your confidence interval includes 1, then it will not be statistically significant. Now, this is the grade analysis that we submitted. So we have 3 outcomes that were included as part of the grade analysis: all-cause mortality, omphalitis, and cord separation time. And what the summary of finding table reports is the absolute effect. So if there are, say, the mortality rate is 18 per 1,000 in the control group, if we apply chlorhexidine, it will be reduced by 3, so reducing it to 15 per 1,000, and that is based on this relative risk. Based on the data from 5 randomized controlled trials, more than 100,000 kids, and we rated this as a low certainty of evidence, and the reason was that we were worried about risk of bias in some of the studies, and that this summary estimate was not totally precise. The omphalitis data was more convincing, and here we allocated as a moderate certainty of evidence that it would reduce the incidence of omphalitis from 87 per 1,000 to 62 per 1,000 with this much of a relative risk. And that similarly, it is fairly convincing that the application of chlorhexidine will increase the cord separation time. Now, just to make a point, there is follow-up studies looking at if this increase in cord separation time would increase the risk of mortality, and that is not the case. So even though the cord separation time increases, it does not have other consequences as part of it. Now, we have about 14 more minutes, and I'm going to wrap this up so that we have some time for questions as well. Now, the question is this evidence enough to recommend, right? So we looked at the mortality benefit, we looked at the omphallitis benefit. So should we not recommend, right? So once the evidence is available, then you look at evidence to decision table. So there are ways to assess the evidence. So you want to look at your desirable effects and undesirable effects. So for example, if this intervention gives a lot of benefits in terms of the outcomes, but then also have increased risk. For example, I was talking about, cord separation time. So how much is the balance? Is it worth really increasing the cord separation time to prevent omphallitis and mortality? Which it seems like is the case. What are the values? Is it available? And we know that in the community settings, there is a lot of applications to the umbilical cord stem because of the different beliefs. So would this be really taken in the community? What resources do we even have chlorhexidine available in rural settings? Would it be available for all the families or the ones who have just access to certain areas or certain facilities? Is it acceptable? Is it feasible? So based on these the criteria, then the evidence is translated into practice. So currently WHO has recommendations and as part of the maternal and newborn care about chlorhexidine, and the current recommendation is that in circumstances other than um, where the risk is not high of application of harmful substances to umbilical cord, the the clean dry umbilical cord care is recommended, and that's sort of mostly what the AAP says for high income countries as well. But in circumstances where the harmful traditional substances risk is high, the application of those substances are high, the WHO recommends that the chlorhexidine should be applied. Now, we have different opinions about it. We think that it's very difficult to have the data for application of harmful substances to the umbilical cord. So what we think and what we suggested in our Cochrane review is that it should be offered in most of the community setting. And there are more nuances to it. If you look at the trials from South Asia, the effect was very apparent, but the two African trials did not show any beneficial effect of chlorhexidine. So when this data was initially published from South Asia, there was some recommendation to apply chlorhexidine. However, the current WHO recommendation stands here, and it includes a number of things that I mentioned earlier, and they also have conducted something called an IPD analysis to come up with some of these recommendations. And in that analysis, they did not look at the omphallitis data, which we think is very important. So what we're hoping is that with publication of our data, we'll be able to reignite the discussion around the approach for umbilical cord care in community settings in low and middle income countries. So we're about 10 minutes away. I'm going to stop kind of presenting the data. I'm very briefly going to talk about my journey. And you know the man on the right. He's been very kind. I give him good health and long life. I've been working with him since 2008 when I graduated. I have published very extensively with him, and the work has been very well received. As Safdar mentioned initially, I have more than 90 publications. They have been cited very well. My H index is 43 and I-10 index of 61. This is very encouraging and rewarding that the work that we have published is not only published, but it has been used in different circumstances as well. I'm very thankful for my family. My wife, Uzma, is a general pediatrician and is interested in childhood obesity. She was awarded an NIH grant very recently. My daughter Zermine, she brings smiles to my face every day, and Shazin, he's 11. So with these people, I try my best to do something good every day, and I appreciate the time, and it is my pleasure to really talk to you guys, and I'll be happy to take any questions.
Thank you so much, Amr. This was a little too complex for me, but I think this was wonderful. One question I have, Amir, and this question is because you see there is huge, revolution going on in AI
All right.
and newer AI models, they can do things which you would not have imagined, like even like 5 years ago. Like, I'm talking about the models which have, like, large language models with a lot of power, like, to look deeper into the data and can actually do things for you uh, without going into all the nitty-gritty details, which we used to look each study and look into it, right? So what do you think is the future of systematic review and meta-analysis, considering how things are moving very rapidly on that domain?
Yeah, I mean, there are newer tools that would simplify some of the processes. Like, for example, Covidence have a model built into the software that, depending on your initial selection of studies, it will bring on the studies that are more relevant to your question. So it really help expedite that. There are also softwares that would help do the data extraction for you. There are also now more facilitated version of things where, for example, if you have very basic knowledge of statistics, actually the large language model like ChatGPT and other, they can help you write the codes and do the meta-analysis. The way I look at it is that the process, it takes a long time to do a comprehensive systematic review and meta-analysis. So the AI may not take over the whole process. You still need to know your basic. You still need to come up with the right question. You still need to be able to say which study is a good, study, or how you're going to interpret the data. But the process to conduct the systematic review would become relatively simpler and probably faster than how it was before. And we have been using some of that, and there are newer sort of evidence that is coming in terms of the evidence synthesis itself and part of the systematic reviews and meta-analysis, and there is also use of AI in developing clinical practice guidelines as well. So I think it's a combination of both, that you supervise the AI or take it as a help rather than replace. I get really worried when you just rely completely on, like, if, for example, if we would not have known any of this and we just want to know, you just ask ChatGPT to tell you how does chlorhexidine work, I would have been very apprehensive about it unless and until I looked at the data myself, if that makes sense. So it's not going to replace on how we synthesize, but it definitely is very helpful in taking and executing some of the tasks that are part of this comprehensive process to evaluate evidence of an intervention for a certain condition.
It's interesting. I want to share like a small experiment I did. This model from the Claude Opus 4, that is very powerful coding model. I did try to put a research question. I mean, I have that the higher end version, and I tried to see if it can generate the whole systematic review and meta-analysis. It did, but when I looked back all the references, and there were a lot of mistakes.
Yeah,
There were so many errors, and I got like, okay, so it is not as helpful as I thought. Because
yeah,
I could see some of the references were just hallucinations. They were not actually real references. So I think, and the reason I'm bringing this question, I think this is mainly for the younger generation because a lot of them, they are interested in using AI to actually, help finding those research studies. But at the same time, they have to make sure, like, they are looking back the actual references. They are actually sometimes just hallucinations. So that's
yeah.
another problem we are encountering.
Indeed. Indeed.
Okay. Anyone else, please go ahead and unmute yourself. If you have a problem unmuting, just let me know. Please go ahead for any questions from the audience.
Either the talk was too good for a question or nobody understand anything and have no question.
Thank you very much. Can you hear me?
Yeah,
Yes,
go
okay.
Go ahead, Dr. Batul.
Hi, this was an excellent presentation. Thank you so much, Dr. Imdad. We actually at Upstate miss you a lot, and I just wanted to tell you that Dr. Sultan Zafar is a huge fan of yours, and he keeps recommending your work whenever we're looking for any data on any topic or trying to analyze something. We're currently working on a systematic review of literature on BPD for our pulmonology clinic. And if you could kindly, if you don't mind sharing your details, and I can maybe share some data with you and see how you feel about it, if you don't mind.
Absolutely. Absolutely. Just reach out and I'm actually still I'm a visiting faculty at Upstate. So even in your own Outlook, if you just type in my name, you will find my email address there as well. You can reach out.
Perfect.
And I can I can share my email with Safdar, and he can definitely reach out to everybody. And yeah, I'll be happy to look at it. And if you need help, absolutely, it will be my pleasure.
Thank you so much. And just out of personal experience, I'll say that whenever I've gone the AI route, I've always regretted it.
Yeah, yeah.
There's no shortcuts in research.
That is correct. That is, you have to be really good. You really need to know your substance very well.
Agree, 100%. Thank you so
I have
much.
to be able to say, okay, well, I will take this and I won't take this. You know, I use AI quite often, but I don't use it in the places where I'm myself not comfortable. If I cannot say this is, this is what it is, then I wouldn't just completely rely on AI. And I have found multiple times that it hallucinates. So you have to be really, really good on your subject matter to make it work for you.
Agree. It sometimes even adds to your work because you might find something that you then seek to verify of on another level and which may or may not be worth the effort. So, if you go the traditional route and look up your references, do your research, that's kind of easily defensible, I would say, more easily defensible versus doing something that is, AI generated and it's truly not defensible in any forum. I agree. Thank you.
Dr. Khan, please.
One follow-up question, I'm taking from the conversation. Aamer, is it okay? Because I get a lot of requests from the medical students and the observers who are interested in research, like, the sort of research we're talking about, meta-analysis and systematic reviews. Is it okay if someone is interested in, I can, channel them towards you?
Yeah, that would be okay. Yes, it'll be. I do work with some of the students back home, and I do work with trainees quite often. So yeah, it will be my pleasure. Absolutely.
And I think Dr. Junaid had a question. Dr. Junaid.
Yeah, thank you, Sardar, and thank you, Amr. Really nice talk. Uh, I'm basically because talking about for the audience in Pakistan.
Mhm.
So, Amir, inshallah, we will bother you again if you can a little bit simplify that because a lot of websites, a lot of resources which you and I can access, not in the Pakistan. And so they need a very basic, tool or basic research work to start with. So there are many, I saw many fellows and the names which I can recognize, and they're not asking the question. Maybe the reason is that, Amir.
Yeah.
So
Yeah.
can you comment on that?
Yeah, absolutely. And the reason and I kind of thought about this on how extensive should I go into. The idea was to really give sort of a more holistic view and not oversimplify things. In order to produce quality work, we really need to make sure that all the things are taken care of. But depending on the question and how much work it is, there are some resources and again, for example, if somebody wants to learn how to do say, meta-analysis or how to do a risk of bias assessment, in other conditions, circumstances, like in a workshop scenario, I'd be happy to say, for example, use the Excel to do the meta-analysis. I can teach people that, if somebody knows data or if they want to know, review manager and that sort of a thing. Or in a workshop scenario, we can exactly retrospectively looking, we could have actually given the data to the audience and say, okay, we're going to pool all this data from these 5 randomized trials. So obviously in an hour, I didn't want to oversimplify it, and hopefully I didn't, did too much of it. There are more nuances. There are more things that I could say that I did it.
No.
I do think that in the future, if there are opportunities for us to interact with trainees, this could be very well simplified to a very basic level so that they have like an initial experience. And once you get a grip of the initial process, then you can learn on top of that and make yourself better.
I think that's a good idea. Sardar, whenever you have APPNA meeting there, you bring Aamer with you, and we can arrange a workshop. Indus, I think having their 2 years conference, every 2 years they have in April. So if it by chance, if he has a time or something, so I want something very to start with. So that, as Ahmed is himself is saying, to be basic, and if we can conduct 1 or 2 really live workshops, so they can interact with each other.
Yeah, I agree with you, Dr. Dinesh. I think, on a lighter note, I think we have to break it down to like a teenager level, right? So that's where we are. Many of us.
Listen, don't talk about the age, okay? It's a very sensitive matter. So that's a different story. But of course, I think we have to do something for our younger generation in Pakistan.
Yeah, but I want to caution one aspect on this, which Amr actually touched on it. I think people say like no pains, no gains. You want to learn in a hard way so you can
Sure.
defend your work, like because it's
Sure.
not just publishing stuff. You also have to defend it for different.
Mm.
For example, if you
Yeah.
do a meta-analysis, excuse me, and systematic review,
Mm.
and
Mm.
someone asks you, hey, can you come in the conference and, just break down everything? How did you do
Mm.
it? So you have to learn the whole process. And it's
Exactly.
also good for yourself too. Like, you can actually learn a lot of things which probably nobody will teach you if you
Mm.
go yourself the hard way, just like Amr was trying to break it. I think the point Amr was making, meta-analysis, systematic reviews, they are not simple things. It has
Mhm.
a lot of, different details in it, which you have to learn. And if you do learn the hard way, then I think then you are on the highway. Then you can actually do amazing things from that experience.
Mhm.
Right.
All right. So there
That's
we
that's very true.
Yeah, we're getting some more questions in the chat, and I'm responding to some of them. So one question was that, can you please recommend some additional resources for learning how to do a systematic review and meta-analysis? And this is a kind of all new for many of us. Again, so Cochrane website has a lot of good material, and it kind of goes through, for example, if you are in a circumstances and you are looking at, say, how to define a question, so there's a chapter on it. Then you're looking at literature search, there's a chapter on it. And it's actually so it's freely available. It's very nicely done. There are also videos of it as well. So Safdar, maybe as part of the follow-up, we can put together some of the resources around it that we can then share with the audience, as part of your group in neonatology. I can provide some of the links so that if you are interested in doing some, there is some reference material right up there that you can use. And then obviously there are people in Pakistan who have done, so Dr. Bhutta has a team in Pakistan. Dr. Jay Das leads that team. I know the last time when I was part of the conversation for this group, there is an effort from Cochrane Pakistan as well. So there are expertise in Pakistan who can help the trainees and provide mentorship. And obviously us here in the US can also take care. And the way I look at this as part of the mentoring team is that, say for example, if there's a neonatology subject, so I may not be the content expert, but I can provide mentorship in terms of the meta-analysis and interpretation of the data. So you may reach out to more than one person at a time if you are interested in a certain, say, question that you want to conduct a systematic review and meta-analysis. If you do it really well, you can publish in a very good journal. And as I showed you guys some of the citations and the work that I do, that we did, it's very well received. So high quality systematic review meta-analysis could be very consequential and very influential in terms of how it is taken up. And we have been very lucky that some of our work was taken up at the highest level. So vitamin A supplementation guidelines by WHO are based on our Cochrane review that I showed you guys. The current American Gastroenterology Association has a guideline based on two of the Cochrane reviews that we published. So it's very, very influential work, and it really set the stage for you for your academic work to grow. And for me, it's very, very rewarding that the time that you spend by doing this work in a very comprehensive way is then taken up at the highest level. Then Naveed is asking what factors are important to look for to do a meta-analysis, and not all systematic we can do meta-analysis. So Naveed, in when you are thinking about meta-analysis, first you really need to see, of all the studies that you are thinking to include in a systematic review, are they similar enough, like their population, their intervention, their comparison, their outcome? No, in an ideal situation, all the studies should be same, but the fact of the matter is that they're not exactly the same. Like the data that I showed you guys, for example, Nepal trial was a different trial, Pakistan trial was a different trial. Similarly, Bangladesh trial, the Tanzania trial, Zambia trial, well, they're all different, but we were able to group them in a way that the comparison were only chlorhexidine versus no chlorhexidine. So you need to look at if the studies are homogeneous enough, and then they have the data in the right form in the outcome that you are looking for. So before you start and do all the work, you need to have some sort of a basic grip of the data that is out there before you do a very comprehensive effort. So those are some of the things. And I think reaching out, for example, if you have something in mind that you want to do and look at, you can reach out to any of us. We can say, hey, there might be enough substance to make a full-blown effort in this particular regard. But that's very important. That's very important. If you feel like that the studies will be very diverse and they're not going to be enough homogeneity in the studies, then that's actually the most common criticism of a meta-analysis, that the studies were not similar enough to be pooled together. So talking about that early in the process is helpful. All right, there are other things as well. I know Dr. Sajjad is here. I don't know if you have any questions. I can take your questions and come back to the comments if you want. But Dr. Batul writes that suggestion back in medical school, we used to practice with doing PICO presentation in rounds. That may be a good place to start for interacting with literature and getting comfortable with trials. That's again, is I think it's important. And I wish there is a trainee group that we can even interact with the trainees. And I love to interact hands-on. Initially I thought I will put up a lot of questions and put the trainees on the spot, or what do you think? What should we do? Those interactive sort of sessions are very educational in nature, but we had an hour, so I thought that I will just present the core of the the knowledge around this and sort of anchor. But I'm pleased that the discussion is kind of revolving around it, and we are talking about more opportunities. But yeah, PICO questions and related things are one way of doing more educational activities. Dr. Sajjad, do you have any questions for me?
No, thank you very much. I think with the permission of the President, Dr. Safdar Sultan, I just wanted to say a lot of thanks to you for this very, very well presented session and very educative and a lot of learning for me. And I think the discussion was also very good. And thank you for offering your support to the young trainees in Pakistan, which I think is a blessing for all of them. We do have a group of neonatal research. Probably we can reshape it and get the help of yourself and all other senior colleagues and researchers who can support and help and guide the trainees on an ongoing basis. So I'll try my best to activate that group, inshallah. And thank you very much. I'm really, really thankful to you. You have taken your time and effort and educated us a lot today. Thank you very much. Thank you, Dr. Safdar, for arranging everything as usual. Thank you.
Thank you.
And thank you to all the participants.
Yes. And some of the people are asking if there is a recording that could be available, and I'm just replying in the chat. I know you're gonna share the recording with everybody. And Dr. Sajjad, I will be, and I've been talking to Safdar about some of the activities that we're planning in the future. So I think this is the right area. I think we can develop expertise in this area. And the biggest, I think, reward in this is that, we are a country with limited resources, and we may not have a lot of resources to do a lot of studies that are, say, prospective in nature. And even though, we have examples of great work coming out of Pakistan from Dr. Putta and other colleagues. But what I think is that if we get really good on getting to know which evidence is great and how can we use it in our own settings, I think that skill itself might help us do really well with some of our patients. Unfortunately, and I happen to know some of the care for some of the relatives that are in Pakistan, and the care that is being offered is like way like 20, 25 years ago, some of the interventions that are being offered. So if our trainees, if our colleagues can really get to know which evidence is the best evidence to apply and how to apply that, I think that can really help improve the outcomes for the children that we all take care of. So it will be my pleasure to participate more in this in the future. Things like this. I would love to hopefully come to Pakistan sometime to do this in person. And as we work more, Safdar and I will hopefully arrange a day or two, sort of a workshop like scenario where we will create opportunities where people can get certified in these skills. And that's where we could show them hand-on skills. Like I can literally be there and have a trainee or a junior faculty conduct a meta-analysis and give them like a feedback right there and then. So I think there are opportunities in the future, and I'll be very pleased to participate in that.
Thank you very much, Dr. Imdad, for your very profuse and open help. And with your leadership and the other senior colleagues and your mentorship and their mentorship, I'm hopeful that we'll be able to create some form of interactive, ongoing connection between the trainees and the seniors and develop this area, which actually is very underdeveloped, but needs a lot of effort to develop as well as expand. Thank you very much. Really appreciate that.
Absolutely. Yeah. Thank you for the opportunity.
And inshallah, we will continue to have, we will come up with more topics, like similar topics, probably in future as well, broken down into probably, for the trainees in future, inshallah. Well, thank you so much, everyone. On weekend, you did it.
Thank you very much. Thank you very much. Our host is great. We know that. Thank you, Dr. Safdar Sultan. We have really brought a very big and positive change to our educational activities.
Yeah.
And APPNA Pediatrics, we really, really appreciate that.
Absolutely.
My
Absolutely.
pleasure.
This,
Thank you
these
so
Zoom meetings have been very, very helpful, connecting all us together at least once a month.
much. Yeah, you are so kind.
Thank you so much.
Thank you very much.
Thank you, everybody. Allah Hafiz.